Like I want whomsoever present to acknowledge faster. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box so that I can able to see you people and begin the class. I want whomsoever. Okay, much better. Okay, speaking about this, people. So speaking about this, we are going to talk about the medicine. So we have talked more importantly the GI and the hepatobiliary system and your urology back in the like surgery. So our main interest of choice in the medicine would be of a neurology at first, followed by endocrinology and nephrology and rheumatology will be the medicine dominated areas. Okay, well, whatever we have seen in surgery, the surgery dominant areas will be GI, hepatobiliary, and urology, while the medicine dominant area could be of four systems, very importantly speaking: rheumatology and cardiology and neurology and nephrology and endocrinology would be the, like a medicine dominated system. So as we have studied already most of the things in your basics, what we are going to cover here is like the disorders, their management protocols, and what are the types we are having, so that we can able to review more, you can able to answer most of the questions. Okay, if your patho and the pharma and micro, if these three are good, then you can able to answer at least 30 to 40% of the questions from the medicine two people. Okay, you need to know that. Okay, now speaking about the neurology. So speaking about the neurology, the first thing we are going to talk about here is your UMN and LMN lesion, people. Upper motor neuron and lower motor neuron lesion. So as we said, like there is a upper, like your motor cortex will, you have this brain, and the brain we have this primary motor cortex. From the primary motor cortex, your upper motor neuron will carry the fiber, and then it goes till the spinal cord, and it goes till the spinal cord, and then from there the lower motor neuron will carry it to the target organ. Lower motor neuron will carry it to the target organ. We have seen that in the physiology. SR no transmission of your motor nervous system. So this is your UMN and this is your LMN. So clinically speaking, we are having symptoms associated with the upper motor neuron, and there are certain diseases associated with the upper motor neuron defect and lower motor neuron defect, people. So we need to know about what are the UMN lesions and what are the LMN lesions first. So first, in the upper motor neuron, you may see the weakness of a group of muscle. Okay, where you see the weakness of group of muscle, while in the lower motor neuron, where you may see the paralysis of your individual muscle, people. Where here you may see the paralysis of your individual muscle. For upper motor neuron, it is a group of muscle. Apart from the tone, what type of muscular tone you may observe? Clasp knife spasticity you may see. Spastic paralysis, you may see it in the upper motor neuron, while lower motor neuron, you may see the flaccidity. Okay, spasticity is upper motor neuron, flaccidity is lower motor neuron. And apart from that, wasting of muscle is minimal in the upper motor neuron, while it is severe in the case of your lower motor neuron. And plantar reflex extensor, which will be seen in the upper motor neuron, and a flexor, you may see it in the lower motor neuron. Okay, so that's a Babinski sign. So plantar reflex, the thumb will extend in the case of your upper motor neuron, and thumb will be flexed in the case of your lower motor neuron. And then you have ALS, amyotrophic lateral sclerosis. ALS is one of the diseases where you need to know in terms of your motor neuron defect, motor neuron degeneration, and the death of your both LMN and UMN could result in ALS. Both LMN and UMN could result in ALS. And if there is 2 to 4 of your motor neurons are involved, then it is a definite ALS. If it is 2 involvement, then it is a probable. Then 1 involvement, then it is a possible ALS. Okay, so motor neuron degeneration diseases, so-called as ALS, 2 to 4 motor neurons should be degenerated or involved in terms of your diagnosis in order to make your diagnosis and treatment. Riluzole is a treatment, people. Riluzole is a treatment, and the mechanism of riluzole is inhibition of glutamate release Add injection edaveron you can able to do. That is a free radical scavenger. You can able to treat it for the, ALS. Okay. Nowadays, research method has been lot of researchers are going on with the ALS to, to make the life comfortable in the ALS patient. And a lot of lobby is playing over the ALS. But so far, what are the things for the FMG you have to know? Motor neuron degeneration, 2 to 4 motor neurons are involved. Riluzole is the treatment of choice, or edaveron is the treatment of choice. Riluzole is inhibiting the glutamate release, while edaveron is a free radical scavenger, people. Free radical scavenger. Apart from that, what are the diseases associated with the UMN? Only UMN lesion and only LMN lesion. Okay. Diseases associated with the UMN lesion are primary lateral sclerosis, and only LMN lesion are Kennedy's disease, Tay-Sachs disease, GM1 gangliosidosis, and spinal muscular atrophy. So Tay-Sachs, GM1 gangliosidosis, spinal muscular atrophy, and Kennedy disease are the one which involve only your lower motor neuron, while only your upper motor neuron, primary lateral sclerosis. Both UMN and LMN, ALS, amyotrophic lateral sclerosis. Apart from that, aphasia, we are having 3 types of aphasia, people. So one is from the Broca's area. We have the Broca's area, and then from the Broca's area to Wernicke's area, and Broca's area to Wernicke's area, connection is mediated by arcuate fasciculus. Okay, connection is mediated by arcuate fasciculus. So here you have this, like a Broca's area to Wernicke's area connection, which is mediated by your arcuate fasciculus. So what is this Broca's area and Wernicke's area indicates? So the Broca's area indicates the fluency of the speech, while the Wernicke's area indicates the comprehension of your speech. Okay, Broca's area is the fluency, while Wernicke's area is the comprehension. Okay, Broca's area is fluency, while Wernicke's area is comprehension. And Broca's area lack any abnormality, or when the Broca's area is not functioning, you get a Broca's aphasia, and Wernicke's area is not functioning, then you get a Wernicke's aphasia. And if there is a problem in the arcuate fasciculus, you may get the conduction aphasia, people. You may get the conduction aphasia. So Broca's aphasia, Broca's area defect, the conduction aphasia, arcuate fasciculus defect, and Wernicke's area, Wernicke's aphasia, Wernicke's area defect. So Broca's area defect, fluency will be impaired. So the people will be doing a comprehensive speech, but there is no fluency and repetition, people. The people will not speak the people can able to give a comprehension speech, but you cannot able to speak fluently. Okay, they may speak word by word. Okay, like if you want to go to the a shop, he say go shop, and he don't say like in a comprehensive way. He don't speak it in a fluent way. He say like a go and shop, and so that you can able to get his comprehension what he wanted to do, but he cannot able to speak fluently. But apart from that, you may see the conduction aphasia, where fluency will be normal, comprehension will be normal, but repetition will not be there. But repetition will not be working in the conduction aphasia. Apart from that, Wernicke's aphasia, as I said, comprehension will be lost. Patient will talk nonsense. He will talk completely, but you cannot able to understand any of this. Okay, that is so called as Wernicke's aphasia. Fluency will be normal, but there is no comprehension in his speech. So he will be like that, talking nonsense for a long time. Okay, and apart from that, there is no repetition. So you need to know about the differences between Broca's and Wernicke's aphasia. Broca's aphasia, normal comprehension, lack of fluency, and repetition. Wernicke, lack of comprehension, normal fluency, and lack of repetition. Well, conduction, both will be normal, except the repetition will not be working. Okay, conduction aphasia is due to arcuate fasciculus defect. Conduction aphasia is due to arcuate fasciculus defect, people. Apart from that, you have an anomic aphasia. Anomic aphasia is due to head trauma, or a metabolic encephalopathy or Alzheimer's disease. Most commonly, you may see it in the Alzheimer's disease, people. Okay, most commonly you may see it in the Alzheimer's disease. Anomic aphasia means inability to recall the names. Okay, inability to recall the names. Okay, that is so called as anomic aphasia. Anomic aphasia. Okay, then apart from that, you have the headache. Next important topic in the neurology in terms of your medicine is your headache. Speaking about the headache could be of migraine or cluster. So what is the criteria we use for the migraine? Very important criteria. That is your Midas criteria. Another important MCQ. Midas criteria is for the migraine attack, and you have the two types of headache. One is your cluster headache. Another one is your migraine. One is your cluster headache. Another one is your migraine. Apart from that, there is a tension headache where it shows a band-like headache. We'll discuss that later. Speaking about the migraine, what type of headache you may see? It is a usually lateralized, and you may see it in the frontotemporal area. You may see it in the frontotemporal area. This migraine, like this migraine headache. But in the case of a cluster headache, you may see it in the periorbital right region. You may see it in the periorbital region. You may see this cluster type of headache. Apart from that, incidence more commonly in males, while migraine more commonly in females. And apart from that, presentation, begins without any warning. So patient, even with the sleep, they may wake up from the sleep and they may think that the patient is having a headache. Okay, he cannot able to sleep because of the headache. So this is a typical one, wakes up from sleep due to headache. That is a common one. You may see it in the cluster headache. While presentation of your migraine, mostly it is preceded by your aura, and mostly you will be seeing after awakening. Okay, mostly you will be receiving the headache after awakening. So what are the cluster headache? Lateralized and periorbital type of headache. While in terms of migraine, it is usually lateralized, but frontotemporal may be generalized. Okay, incidence male over female in terms of cluster, and female over male in terms of your migraine. And presentation begins by aura in terms of migraine, no warning in terms of cluster headache. Presentation wakes up from sleep in terms of cluster, after awakening in terms of migraine. Okay, wakes up from sleep in terms of cluster, after awakening in terms of your migraine. What are the treatment of choice for the migraine, people? What are the treatment of choice for the migraine? Speaking about the treatment of choice for the migraine, the prophylaxis of migraine is your amitriptyline, beta blocker, calcium channel blocker, dothipin, valproate, topiramate, methylsergate, pizotifan, and nortriptyline. Amitriptyline and nortriptyline are the one we typically uses for the prophylaxis of your migraine. Apart from the treatments such as triptans, NSAIDs, dopamine antagonists, NSAIDs, and dopamine antagonists, you have to remember. And apart from the tension headache, band-like pain, you may see the type of headache as a band-like pain exacerbated by emotional stress, glare, noise, and fatigue. Okay, when you are looking at something in the bright area for a long time, or whenever you may see that there is a lot of noise, and whenever you may see there is a lot of emotional stress, that's the time you may see the tension type of headache. Okay, and associated with the focal neurological symptoms, associated mostly with the focal neurological symptoms. So we have talked about the headache, we have talked about the aphasia, and we have talked about the UMN and LMN lesion. Now the important area we are going to talk about is your seizure. Very important area in terms of your neurology is the seizure. So seizure could be focal seizure or generalized seizure. Focal seizure or generalized seizure. Focal seizure could be simple partial seizure and a complex partial seizure. Simple partial seizure and a complex partial seizure. While generalized seizure, we are having a 6 variety of generalized seizure, where tonic-clonic seizure, tonic seizure, clonic seizure, atonic seizure, myoclonic seizure, and absent seizure. So what are the 6 type of generalized seizure? Tonic-clonic, clonic, atonic, myoclonic, and absent seizure. All of a generalized seizure, what is the drug of choice, people? As I told you in pharmacology, any of the generalized seizure, what is the drug of choice? The drug of choice is sodium valproate. Drug of choice is sodium valproate. You have to remember that. Now, speaking about the simple seizure and focal seizure, so the focal seizures are associated with, first one is associated with the Todd's palsy and the Jacksonian marks. And apart from that, you have it in the behavioral arrest and andrograde amnesia. Behavioral arrest and andrograde amnesia, Toad's palsy, Jacksonian march, all the are the 4 types of diseases associated with the focal seizure. Among that, Toad's palsy and the Jacksonian march are without the dyscognitive features, while in terms of your behavioral arrest and andrograde amnesia is with the dyscognitive features. So with and without dyscognitive features, the syndromes associated with the focal seizures we have seen. Toad's palsy, Jacksonian march without dyscognitive feature. Behavioral arrest, andrograde amnesia is with the dyscognitive features. Apart from that, generalized seizure, speaking about the generalized seizure. So first tonic seizure is a tonic contraction. Tonic seizure is tonic contraction. Tonic contraction. While clonic is clonic contraction. While clonic is clonic contraction. While atonic seizure is, while atonic seizure is absence of contraction or absence of tonic contraction. And myoclonic seizure is a myoclonic jerk. Okay, myoclonus will be there. And apart from the tonic clonic seizure, the most common symptom is, activation of your sympathetic tone. Most common one is your activation of your sympathetic tone, and you may see the post-ictal confusion over this people. And you may see there is a post-ictal confusion in this patient. Now, apart from that, you may have an absence of seizure. There is a typical case scenario you may be asked with the absence of seizure. The typical case scenario you may be present with the absence seizure is you have the slow spike and wave appearance on EEG. There is a rapid blinking of eyes. You see that there is a rapid blinking of eyes followed by staring of the wall. Okay, followed by staring of the wall is the exact scenario they may ask you people. So rapid blinking of eyes followed by staring of the wall is the classical Vineyard-based clue they may give you. And apart from that, EEG shows slow spike and wave appearance. Slow spike and wave appearance on the EEG is also presented by your absence seizure. As per the absence seizure, drug of choices sodium valproate. If it is less than 2 year old, if it is less than 2 year old, if it is less than 2 year old people, ethosuximide is a drug of choice. So as per the thing, we won't follow the drug of choices in the clinical practice people. So since medicine is dealing with the clinical practice, we talk about the first line, second line and third line of treatment. Okay, first line, second line and third line of treatment, we used to call it up. Okay, first of all, focal seizure. What is the drug of first line of drug we use is carbamazepine, lamotrigine, oxcarbamazepine, and phenytoin. Tonic clonic, valproate, lamotrigine, topiramate, clonazepam, clobazepam, and levetiracetam. And apart from that, you have a myoclonic, valproate, clonazepam, clobazam, and levetiracetam. Absence, ethosuximide and valproate. Lennox-Gastaut syndrome, valproate and lamotrigine. Infantile spasm, ACTH. That is your this one. What do we call it? West syndrome or juvenile infantile spasm is so called as West syndrome. Drug of choice for West syndrome is your ACTH. And pregnancy anti-epileptic of choice is your carbamazepine people. And for focal seizure also we use as carbamazepine. Remember that focal seizure also we use as carbamazepine. And pregnancy we can use as this carbamazepine. And pregnancy also we can use as this carbamazepine. Okay, now apart from that, you have the stroke and TIA, transient ischemic attack along with the stroke. So within 24 hours, how does that patient comes to you with the typical stroke people? How does the patient comes to you with the typical stroke? Old man with or without comorbidities, or any young man, a person with or without comorbidities, I rather write a person with or without comorbidities presented with unilateral muscular weakness or paralysis, unilateral muscular weakness or paralysis, muscular weakness or paralysis, along with angle of deviation of mouth or deviation of angle of mouth. I rather write it here. Deviation of angle of mouth, along with deviation of angle of mouth, is the typical stroke case, people. Is the typical stroke case. You may see it in the patient. Okay. Person with or without comorbidities presented with the unilateral muscular weakness or paralysis, unilateral muscular weakness or paralysis along with the deviation of angle of mouth is a classical scenario of your stroke patient. Okay, the case scenario they may give you is classical case scenario. Person with or without comorbidities presented with the unilateral muscular weakness or paralysis along with the deviation of angle of mouth. Okay, now speaking about that, within a 24 hours, if the symptoms has been resolved, then it is a TIA. Okay, then it is a TIA. So transient ischemic attack. In the transient ischemic attacks, you may see the amaurosis fugax. Very important MCQ. Amaurosis fugax. We studied that in the pathology also. So in the ophthalmological examination, you see the amaurosis fugax, and the CT scan will be normal. And the CT scan will be normal. And the criteria we use for the transient ischemic attack is ABCD2 criteria. ABCD2 criteria we use for the stroke or transient ischemic attack. If it is over, the symptom lasts over 24 hours, then it is a stroke, people. Then it is a stroke. We classify the stroke as a ischemic stroke and hemorrhagic stroke. Okay, we classify the stroke as ischemic stroke and hemorrhagic stroke. Speaking about the ischemic stroke, we are having a thrombotic and embolic stroke. We are having a thrombotic and embolic stroke, and a thrombotic stroke is due to the atherosclerosis, people. Thrombotic stroke is due to the atherosclerosis, and embolic stroke is due to the embolus, you already know. Apart from that, hemorrhagic stroke, which is due to the parenchymal one, or maybe due to the subarachnoid hemorrhage one. The most common site is your ACA, where you see the worst headache of your life, or it may be due to the epidural hematoma or hemorrhage. Most common site is your middle meningeal artery, where you see the lucid interval and lenticular opacities. You studied that in the trauma back in your surgery, where you may studied in your surgery class. Epidural EDH, most common site is MMA, where you see the lucid interval and you see the lenticular opacities. And similarly, subarachnoid hemorrhage, most common site is your ACA, where the patient experiences worst headache of your life. These are the key words you may see, people. And subdural, half moon appearance or crescentic hematoma on the CT. Half moon appearance or crescentic hematoma on the CT, you may see, you can visualize that image, and then you can able to proceed with that. This is a SDH or EDH or SAH, or it may be due to the parenchymal damage, the blood has been oozed out and the patient is getting a stroke. These are the one you may see it in the case of your hemorrhagic causes of your stroke. Okay. Now, speaking about the management, people, speaking about the management of stroke, this is kind of like a management. You typically do it in the hospital setup whenever the patient comes to you. So this is kind of like a checklist. You have to make sure like you are following all of these things. So whenever the patient is coming to you with the hemorrhagic stroke, whenever the patient is coming to you with the ischemic and hemorrhagic stroke, first we talk about the ischemic stroke. Okay, patient is coming to you with the ischemic stroke. You're doing an investigation of choice. Investigation of choice, and the DWI MRI is the investigation of choice for the ischemic, and for the hemorrhagic NCCT of brain will be the investigation of choice. You found that this is a ischemic stroke. You found that this is a ischemic stroke. Then what is the next step in the management? You are sitting in the ED. Patient has been coming to you with the unilateral weakness and like the angle of deviation of the mouth, and you see that the patient is having a comorbidities, no history of a stroke, and you are ordering the patient with the CT and MRI, and CT showed no hemorrhage, and MRI showed DWI MRI showed a ischemic stroke. You found that it is a ischemic stroke. Then you are what is the next step you are going to do? You have to make sure you have added everything in this patient drug chart first. Okay, first one, you can try the thrombolysis. You can try the thrombolysis with the thrombolytic agent. You can do the thrombolysis with the thrombolytic agent, and if the thrombolysis period has been crossed, then you can able to give any blood thinners, for example like a heparin, or for example like a enoxaparin. Any of this thrombolytic agents you can able to give. One is a thrombolysis, and you have to add a neuroprotective, and you have to add a neuroprotective. Antithrombotics we have already talked about it. Okay, any anticoagulant, neuroprotective. If thrombolysis is possible, then do the thrombolysis. If the thrombolysis is not possible, then neuroprotective, blood thinners. Remember, always you have to add the anti-epileptic. You have to add the anti-epileptics. These three are the drug chart you have to remember. Okay, if any patient comes to you with the ischemic stroke, what is the thing you have to add? First, add the anti-epileptic. Could be any anti-epileptic available in the hospital. Immediately add anti-thrombotics and neuroprotective. If there is a possibility of thrombolysis, do the thrombolysis. Okay. If not, then add a neuroprotective, anti-thrombotics, anti-epileptics. Then, apart from that, monitor the patient's temperature and glucose thing. Monitor the patient's temperature and glucose. So what we do technically, we is prophylactically, we add the pyrexia control, antipyretic, we prophylactically add. Along with that, you have to manage the strict glycemic control. You have to manage the strict glycemic control. For that, we used to call the endocrinologist to take over that glycemic part. Okay, because the strict glycemic control is very, very essential in terms of your ischemic stroke. So neuroprotective, antithrombotic, anti-epileptic, glycemic control, pyrexia control are the 5 things. It should be on the checklist of the patient drug chart so that you are managing him clearly. Okay, stroke is an emergency, people. As early as you do the actions, you can able to save the patient's life. As I said, you have to do it followed by the physiotherapy in the lateral period. Okay, so the improvement will be should be expected in this patient, but the chances are very, very less in terms if the patient ages too much and the patient's having a large ischemic stroke and all, then the chances of revival will be very, very less. Okay, now speaking about the hemorrhagic stroke. Okay, speaking about the hemorrhagic stroke, immediate fluid restriction, head and elevation to 20 to 30 degree. That is the classical thing you do. Immediately, whenever you find a NCCT brain, there is a hemorrhagic stroke or any ischemic stroke with the hemorrhagic transformation, rise the bed to 30 degree, fluid restrict the patient and hyperventilation, add a diuretics and mannitol because there is a possibility the patient may have any hydrocephalus. So add the patient immediately the mannitol and try to reduce the ICP. Okay, if the ICP is not reduced, then try the burhole and evacuate it. So surgical management is the last if there is any hydrocephalus. So this is the management protocol for your ischemic and hemorrhagic stroke, people. So patient comes to you with the unilateral weakness and you see that there is a deviation of angle of mouth, and then you admit the patient in the ED, you are evaluating him, you found it is a ischemic stroke. What is the next thing you will do? Try to thrombolyze. In that scenario, if the thrombolysis is not possible, add him immediately the neuroprotective and anti-thrombotics and anti-epileptics, all the 3, and then follow the glycemic control and pyrexia control. Follow the glycemic control and pyrexia control immediately. Okay, and then you have this hemorrhagic one, then you may see the fluid restriction, restrict the fluids, raise the head end, decrease the ICP, so that add a mannitol or any diuretic, maintain the oxygen, hyperventilate the patient. And if the ICP is still high and the patient cannot able to control it with the mannitol, try to do the burrow evacuation or anything, any neurosurgery that can able to reduce your, like a hydrocephalus. Could be a shunting surgery or could be a burrow evacuation. Anything you can do on this patient. Okay, clear about that? Clear about that? Yes? Clear about that? Yes? Okay, now speaking about what type of artery area, what type of the patient may comes to you. This is a FMGE point of view, people. Very, 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 very important. What artery is having a stroke? If the artery is having a stroke, and what type of symptoms that the patient may experience. This is very, very important. As I said, you have that MCA artery. If the artery is a middle cerebral artery, then the patient may come to the contralateral paralysis and sensory loss in the face. Contralateral paralysis and sensory loss in the face. Apart from that, patient may come to the homonymous hemianopia, people. Homonymous hemianopia. Apart from that, patient will be aphasic, neglect will be there, and gaze towards the side of the lesion will be there. Gaze towards the side of the lesion, neglect, aphasia, homonymous hemianopia, contralateral paralysis, sensory loss on the face. All of these are associated with the MCA territory. If it is a ACA territory, contralateral motor and sensory loss, personality changes, and urinary incontinence. Urinary incontinence, personality changes, and contralateral motor and sensory loss. Then PCA stroke, you have a visual field defect, and you have a preservation, and then you have a memory deficit, homonymous hemianopia will be there. Any visual field defect, you may see that the patient is having a narrow vision, then there is a PCA stroke is possible. Immediately check with the PCA stroke there or not. Okay. And if it is in the, even the amuresis fugax will be captured by within a 24 hours on the ophthalmic evaluation. Yes or no? So visual field defect, PCA stroke. Contralateral motor and sensory loss along with the urinary incontinence, that is your ACA stroke. Paralysis, homonymous hemianopia, aphasia, patient is aphasic, then you may think about the MCA stroke. Then you may think about the MCA stroke. So these are the possible scenarios where you may expect what type of symptoms and what artery is involved. You can able to identify that clinically, people. You can able to identify that clinically. Apart from that, there are syndromes which is associated with the stroke. There are syndromes which is associated with the stroke, and you have the stroke syndromes and the localization. Speaking about the stroke syndromes and the localization, alexia and agraphia, left-sided angular gyrus will be there. Gerstmann syndrome, dominant parietal lobe will be involved. Dysarthria, clumsy hand syndrome, Bassus pontis will be there. Wallenberg syndrome, lack of a stroke in the vertebral artery, PICA involvement will be there. Dorsal cerebellar syndrome, superior cerebellar artery, and Weber syndrome, PCA, and Benedict syndrome, PCA, Claudy syndrome, PCA to the midbrain, Northern-Nagle syndrome, and Perrinoud is also PCA to midbrain, and Dejarin-Rossi syndrome is associated with the thalamic geniculate artery. Is associated with the thalamic geniculate artery. So these are the one you may see it in terms of your. These are the one you may see it in terms of your. The stroke syndromes and the associated localization. The stroke syndromes and associated localization you may see. Then now speaking about it, next is the spinal cord disorders. Speaking of a spinal cord disorders, so we have talked about the stroke, we have talked about the epilepsy, we have talked about the headache, and we have talked about the UMN, LMN lesion and aphasia, people. We have talked most of the situations in the medicine. Now we are going to talk about the spinal cord disorders. So syringomyelia, there is a formation of syrinx. So there is a, since there is a formation of syrinx, so you have the spinal cord. So spinal cord is surrounded by dorsal median sulcus and ventral median commissure, followed by gray matter and followed by white matter. Yes or no? Followed by gray matter and followed by white matter. Consider this is a dorsal median sulcus. Dorsal median sulcus. And this is a ventral median commissure. Ventral median commissure. Adjust my image. Okay, speaking about this dorsal median sulcus and ventral median commissure, like there is a syrinx in the syringomyelia, there is a formation of the syrinx which is in the central canal, and it goes and it grows and grows and grows, and if it affects these areas and it affects these areas. Speaking about the syrinx, formation of syrinx that can affect both of you on the both sides. What will be the thing which you may see, people here? You may see there is a dorsal column, you may see there is a spinothalamic tract, and you may see other tract. So whatever the tract which has been decussating to the opposite side, because of the syrinx, it may get damaged. Only the dorsal column will remain unspared, will remain unaffected. So dorsal column will be spared, and you may see there is a painless burn, and you may see there is a shawl sign. You may see there is a shawl sign, because as I taught you in a physiology, dorsal column carries what type of fibers? As I said you, VAPP. What are they? Vibration, pain, vibration, proprioception, and fine touch. And fine touch or 2-point discrimination, I rather say. So now what happened? You may see the temperature and pain is carried out by your spinothalamic tract. So both tract is not working. So patient may experience a painless burns. So this is a classical condition of syringomyelia, where you may see the shawl sign. Then you have a Brown-Sequard syndrome. There is a contralateral loss of pain and temperature, ipsilateral weakness and loss of vibration and pressure. You may see it in the Brown-Sequard syndrome. Then spinal artery occlusion, ASA occlusion could result in loss of pain and temperature. PSA occlusion could result in loss of unilateral or bilateral vibration and pressure. Okay, unilateral or bilateral loss of your vibration and pressure is seen in the posterior spinal artery occlusion. Then conus medullaris syndrome, S2 to S5 tumor, and there will be a bilateral symmetrical pain on perineum and thigh. Knee reflex will be positive, and ankle reflex will be either positive or negative in the conus medullaris. Then cauda equina, L2 to S1, tumor or trauma. It is resulted in tumor or trauma, asymmetric motor loss, fasciculation loss, and knee or ankle reflex will be negative. This is associated with the spinal cord disorder, people. So what are they? 5 diseases. Syringomyelia, formation of syringe, dorsal column will be remaining unaffected, shawl sign positive, painless burn. Brown-Sequard syndrome, loss of pain and temperature contralaterally, ipsilateral loss of weakness and loss of vibration and pressure. Spinal artery anterior occlusion, loss of pain and temperature, posterior vibration and pressure. Conus medullaris, S2 to S5, knee reflex positive, pain on perineum and thigh, and ankle reflex either positive or negative. While cauda equina, it is a ankle or knee reflex negative, L2 to S1, tumor or trauma, asymmetric motor loss, and loss of fasciculations, you may see. Then apart from the degenerative diseases, so first one is your Alzheimer's. What are the things you have to know in terms of your Alzheimer's is investigation of choices, MRI, people. Investigation of choices, MRI. Alzheimer is a silent epidemic. Very, 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 very important MCQ. Alzheimer's is a silent epidemic. Investigation of choices, MRI. But the screening test for Alzheimer's is MMSE. So that's why I'm putting it in a different color. MMSE, mini mental state examination, is a screening examination we do for the Alzheimer's. And apart from that, biopsy showed neurofibromatory tangles. Very, 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 very important MCQ. Neurofibromatory tangles. And there are 4 gene defects which you may see it in the Alzheimer's. Again, that was asked in a previous FMGE. Location of their chromosome and the gene defect was asked in FMGE. Presnalin 1, chromosome 14. Presnalin 2, chromosome 1. APP gene defect, chromosome 21. ApoE4, chromosome 19. ApoE4, chromosome 19. So investigation of choice, MRI, screening, mini mental status examination, biopsy, you may see the neurofibromatory tangles, and silent epidemic, and 4 gene defect, Presnalin 1, 2, APP, ApoE4. Presnalin 1 is seen in chromosome 14, while Presnalin 2 gene defect is seen in chromosome 1, and APP gene is seen in chromosome 21, and ApoE4 is seen in chromosome 19. So these are the important highlights you have to know in terms of your Alzheimer's, people. What are they? Investigation of choices, MRI. Screening is MMSE. Biopsy is neurofibromatory tangles. And it is a silent epidemic with the 4 gene defect. Presnalin 1, 2, APP, ApoE4. And apart from the treatment, tacrine, donepezil, rivastigmine, galantamine. Among the tacrine is not used nowadays due to the hepatotoxicity. Both of them are the acetylcholine esterase inhibitor, reversible one. And apart from that, you may have one more drug called as memantine, which is a NMDA receptor blocker. So this was asked several times in FMGE. What is the NMDA receptor blocker used to treat the Alzheimer's? That is your memantine. That is your memantine. Then you have a Parkinson. As I said, in the Parkinson disease, destruction of dopaminergic neuron in nigrostriatal tract, where you may see the tremor, cogwheel rigidity, tardive dyskinesia. Very, 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 very important. Tardive dyskinesia, where you may see the shuffling or festinant gait. Okay, apart from that, Mayer sign positive, glabellar tap positive. Mayer sign positive, glabellar tap positive, and you may have a festinant gait or shuffling gait or tardive dyskinesia with a cogwheel rigidity. Classical MCQ people. Tremor, cogwheel rigidity with the dyskinesia of tardive movements is one of the classical MCQ where you may see it in the Parkinson disease. And you may see there is a Lewy body dementia. You may see there is a Lewy body dementia. Drug-induced is benzexol. And you may have this levodopa, carbidopa, entacapone, selagelin, and rasagelin. We studied that in the pharmacology. Apart from the D2 agonists, bromocriptine, apomorphine, rotigotine, and ropinirole are the drugs we can able to give for the treatment of Parkinson disease. Okay, Parkinson disease, as per the medicine, destruction of dopaminergic neuron, tremors, cogwheel rigidity, dyskinesia of tardive movement, shuffling gait or festinant gait, Mayer sign positive, glabellar tap positive. Gene defect, 3 gene defect, PARK1, PARK2, PARK8. PARK1 is alpha synuclein, PARK2 is PARKin, PARK8 is LRRK2 gene defect. Okay, LRRK2 gene defect. And drug-induced Lewy body dementia is seen in Parkinson disease. Classical MCQ people. Lewy body dementia is seen in Parkinson disease. Okay, then you have a Huntington, chromosome number 4, where you see the boxcar appearance. Drug of choice is tetrabenazine. Okay, drug of choice is tetrabenazine, where you may see the boxcar appearance. Myasthenia gravis, antibody against the acetylcholine esterase. Tensilon test, heterophonium, treatment of choices, neostigmine and pyridostigmine. We already knew that. Then Guillain-Barré, acute onset, ascending paralysis, areflexia. 3 classical words. If you see it in the case Vineyard people, you have to blindly choose acute onset, ascending paralysis, and areflexia. Okay, and the treatment of choices, IV immunoglobulin for 5 days. 5 days to 7 days, we can give a IV immunoglobulin. Or if there is or we can do the plasma paresis as a treatment of choice. Plasma paresis as a treatment of choice. With this, we are concluding our, neurology. Speaking about the neurology, we have talked about the UMN lesion. We have talked about the LMN lesion. We have talked about the aphasia. And we have talked about the headache. We have talked about the seizures, stroke, spinal cord disorders. And we have also talked about your degenerative diseases. So entire neurology has been completed. Okay, most of the portion. Apart from that, there you may see the meningitis, fever with the rigid neck, fever, vomiting, rigid neck or nuchal rigidity. Okay, rigid neck, classical symptoms of meningitis. Lumbar puncture will be performed, that you might have studied in your medicine class already. Okay, yes or no? So speaking about that, comprehension is impaired in Wernicke's aphasia, while fluency is impaired in Broca's aphasia, while your repetition is impaired in all 3 aphasias. Anomic aphasia is associated with Alzheimer's. True or false? True. And apart from that, wakes from sleep, what type of headache? Cluster headache. And prophylaxis of migraine, amitriptyline, nortriptyline. And treatment, triptans, NSAIDs, and dopamine blockers we can give. Tension headache is a band-like headache due to emotional stress. What type of seizure is a rapid blinking of eyes followed by staring on the wall? A staring on the wall followed by rapid blinking of eyes with the slow spike and wave appearance on the EEG. Slow spike and wave appearance on the EEG. Absent seizure. Drug of choices, sodium valproate. If it is less than 2-year-old, ethosuximide. Then stroke, patient comes with the unilateral weakness along with the deviation of angle of mouth. Investigation of choice for ischemic is DWI MRI. And investigation of choice for hemorrhagic is NCCT. And apart from that, ischemic stroke is associated with thrombosis and embolus. Hemorrhagic is associated with parenchymal, SAH, EDH, and SDH. SAH, it is a most common site is ACA, where the patient experience worst headache of your seizure. Epidural, which is a most common site, is your middle meningeal artery, where you may see the lucid interval and lenticular opacities. Subdural, crescentic moon or half moon appearance with the crescentic hematoma. Okay, treatment management protocol, we have already discussed about that. MCA's territory, contralateral paralysis and sensory loss on face, aphasia, neglect, and gaze towards the site of the lesion. Okay, and PCA, visual field defect, memory deficiency, and the patient is presented with the perseveration. Okay, ACA, contralateral motor and sensory loss, personality changes, urinary incontinence. Motor and sensory loss, personality changes with urinary incontinence. Then you have a stroke syndromes. We have discussed the important stroke syndrome. And spinal cord anomalies, we have discussed. Alzheimer's disease, silent epidemic, neurofibrometry tangles, investigation of choices, MRI, screening is MMSC. Okay, NMDA receptor blocker used for the treatment of Alzheimer's is memantine. Parkinson, destruction of dopaminergic neuron in the nigrostriatal tract, and 3 gene defect, PARK1, PARK2, PARK8. PARK8 is LRRK2 gene defect. Symptoms, tremor, cogwheel rigidity, tardive dyskinesia, shuffling gait or Festinian gait, Mayer sign positive and glabular tap positive. Mayer sign positive and glabular tap positive. Treatment, drug-induced one, benzoxol, levodopa, carbidopa, entacapone, tolcapone, and rasagiline or selagiline will be used. And all their mechanisms we have discussed. Huntington disease, chromosome 4, boxcar appearance, tetrabenazine is a drug of choice. Myasthenia gravis, anti-ACHE antibody will be there. Tensilon test, mediated by edrophonium. Treatment of choices, neostigmine and pyridostigmine. Guillain-Barré, acute onset of ascending paralysis with the areflexia. Treatment of choices, IgG. Treatment of choices, IgG. Clear about that? Clear about that? Shall I move on to the nephrology next session? Next section, nephrology. Can I move on to that? Okay, speaking about the nephrology, the first one is your anuria. Anuria means complete absence of disease, people. Complete absence of urine. That is less than 100 ml per day. What is anuria? Less than 100 ml per day. And oliguria, less than 400 ml per day or less than 20 ml per hour. Oliguria, less than 400 ml per day or less than 20 ml per hour. Polyuria, more urine output where there is more than 3 liters. So what is the more than 3 liters indicate? Polyuria. Less than 400 ml, oliguria. Less than 100 ml, it is anuria. It is anuria. Then what color indicates what type of pathology? Color of urine and the pathology. Smoky urine, acute glomerulonephritis. Yellow urine, tetracycline. Tea color, hemoglobinuria. And brown color, chloroquine, primaquine, and quinine. And red without a blood, which is a beetroot ingestion. Orange is due to rifampicin. And darken while standing is alkaptonuria. This is the classical MCQ. Okay, urine analysis, smoking or cloudy urine, acute glomerulonephritis, yellow, tetracycline, tea color, hemoglobinuria, brown, which is associated with the chloroquine, primaquine, or quinine. Red without a blood is your beetroot ingestion. Orange is your rifampicin. And darken while standing is your alkaptonuria. Darken while standing is your alkaptonuria. Then you are having this urinary cast and their pathology. Fatty cast, nephrotic syndrome. WBC with the bacteria, UTI. WBC without a bacteria, renal interstitial disease. And RBC, hematuria, hyaline cast, dehydration, or treatment with diuresis. Okay, treatment with diuresis or dehydration, you see the hyaline cast. RBC cast indicates a hematuria. WBC without a bacteria indicates a renal interstitial disease. And WBC with bacteria, UTI, fatty cast, nephrotic syndrome. Fatty cast, it is nephrotic syndrome. So this is all about the urinary cast and the color of urine and the type of amount of urine secretion and their definition. Okay. Now, moving on to AKI, people. So we are going to talk about the AKI and the CKD, and then we talk about the nephrotic and nephritic syndrome. That covers our entire nephrology section. Okay. So speaking about the AKI, The first criteria of AKI we follow here is your KDIGO criteria. So as per the KDIGO criteria, increase in serum creatinine of more than 0.3 in 48 hours. Okay, increase in serum creatinine of more than 0.3 mg per deciliter in 48 hours, or increase in serum creatinine by more than 1.5 times from the baseline in the past one week. Either the baseline creatinine level should be increased more than 1.5 times in the past 1 week, or there is an increased serum creatinine of more than 0.3 in 48 hours, or there is a decreased urine output for 6 hours. How much? For less than 0.5 ml per kg per hour. Less than 0.5 ml per kg per hour. If for past 6 hours, then the patient is having a AKI, people. Then the patient is having a AKI. So what are the conditions of AKI? Either you may have an increased serum creatinine of more than 0.3 mg per deciliter in the past 48 hours, or there is an increase in the baseline creatinine level, which should be 1.5 times increase in the baseline creatinine level for past 1 week, or there is a decreased urinary output of less than 0.5 ml per kg per hour for past 6 hours. For example, consider like there is a 80 kg man. Consider like the 80 kg man, then the urine output should be less than 40 ml per hour, indicates that there is a less than 40 ml per hour for past 6 hours and the patient is catheterized. That indicates that there is a kidney injury, which is a AKI. Okay, as per the KDIGO criteria. Okay, we follow KDIGO criteria, but there are several other criteria as well. Okay, and apart from that AKI, the causes of AKI could be pre-renal, intrarenal, and post-renal. Pre-renal, intrarenal, and post-renal. So what could be the post-renal cause, people? Obstruction. Obviously obstruction, right? Post-renal cause. Not the kidney is not pumping the urine out, so the urine is accumulating in the kidney and it is causing a kidney injury. That is so called as post-renal cause. Yes or no? Possible cause could be of obstruction, right? So either a bladder outlet obstruction or PUJ obstruction would be the cause of your post-renal one. Could be the cause of your post-renal one. Or the pre-renal one, consider pre-renal one in the glomerulus. We have the efferent and afferent arteriole, which resists the blood. So it would be whatever the factors that can able to decrease the volume of blood, or whatever the factors that can able to decrease the cardiac output, or any heart failure that the heart cannot able to pump the blood enough to the respective kidney, or any IV drug abuse, or any drug abuse like NSAIDs, ACEAs, ARBs, and cyclosporin. NSAIDs, ACEAs, ARBs, and cyclosporin. These are the possible drugs that can able to cause a pre-renal AKI. These are the possible situation where you may associate it with the pre-renal AKI. Hypovolemia, decrease in cardiac output, or congestive cardiac failure, or any patients with the NSAID abuse, ACEAs, ARBs, and cyclosporins. Okay, especially we used to see a lot of patients who are the NSAID abusers from the villages, especially in the borders of your Tamil Nadu and Andhra, where there is a Chittoor district or somewhere else near the Tirupati, the rural area people who used to do the farming work, they are having a body ache and they go to the pharmacy and takes the NSAID and they get their pain relief. Over the period of time, they will start abuse the NSAIDs, and patient may develop a AKI secondary to NSAID abuse. We used to see a lot of case with that scenario. Okay, next is an intrarenal cause, which is a glomerulus or tubular or interstitium or associated with the vaccines. Okay, sorry, vasculitis. Okay, tubular, glomerular, interstitium, and vasculitis. Glomerulonephritis, and SLE. Glomerulonephritis, and SLE. While tubular, ischemic due to decrease in renal perfusion, or it could be due to the nephrotoxic. Nephrotoxic means what? There will be the drugs or medicines. Yes or no? So endogenous nephrotoxin ones are your hemoglobin and myoglobin. Okay, fine. Endogenous tubular nephrotoxic one. Apart from that, as I said when I was teaching you the, mucormycosis back in the, back in the microbiology, as I said, liposomal amphotericin B can able to puncture your kidneys, as we said. So amphotericin B, aminoglycoside, and anti-cancer drugs like a cisplatin serves as an exogenous one. serves as an exogenous one. Then you have interstitial medications such as interstitial damage due to the medications such as penicillins and sulfonamides, or apart from that, it may cause an infection such as leptospira, legionella, and you have this, like a hantavirus. All these things can able to cause the interstitial damage. Then you have vascular one. Vascular one is associated with the hemolytic uremic syndrome, where, as we said, there is a triad of your hemolytic uremic syndrome. What was that? Whenever you see the patient with the decrease in hemoglobin, decrease in platelet, and increase in serum creatinine, typically goes to the hemolytic uremic syndrome. Then you have vasculitis and malignant hypertension. These are the things where you may see here on the AKI, and these are the causes of the AKI, people. So whenever you have been called for the AKI, so technically speaking, whenever the patient is coming to you with the, like a lethargy, and whenever the patient is coming to you with the pitting edema, and patient is drowsy, patient says like, I'm having a leg ache, doctor, leg pain, doctor, where I cannot able to walk out. And whenever I walk out, I feel that there is a lot of swelling inside my leg, and the urine is not going. I'm not going passing the urine properly. These are the things that the patient may comes to you with the OPD. Okay, whenever you see that sort of patient, you have to identify the causes of AKI, but that will not be necessarily AKI. That can also be possibly CKD. Okay, so now you are not in the clinical setup, you are in the hospital setup, and immediately you have been called in for the, like you have been assisting, you are in the ED department, and patient is having this thing. And what is the time where you choose the hemodialysis for the AKI patient? What is the time where you choose the hemodialysis for the AKI patient? We rather do it in the three scenario people. One is whenever the patient is having a severe uremic syndrome, hemodynamically compromised uremic symptoms are exceeding. That is the time we do the hemodialysis. Or the patient is having a volume overload with the hyperkalemia. The patient is having a volume overload with the hyperkalemia. Potassium is rising. Potassium, I have seen one patient with the potassium of 7.2. See, potassium of 7.2 with the creatinine of 11. And the patient was presented to us in the ICU to the anasarca. So these are the kind of patients where you need to initiate the dialysis immediately, that too with the 2K bath, whereas you can able to extract most of the potassium out of the dialysis. So apart from that, the patient may be failure with the medical management. Whatever the patient who is failure with the medical management, you can initiate the dialysis. So speaking of a dialysis, it is indicated in three situations: uremic symptoms or uremic complication, volume overload with the hyperkalemia, and failure in the medical management are the three possible scenarios where you may able to diagnose with the acute AKI, and you can able to initiate the dialysis in this patient, HT in this patient. Apart from the CKD, progressive decrease in GFR that you may see over a period of time whenever the patient is coming to you with the, like abuse of your long-standing diabetes, long-standing hypertension, diabetic nephropathy. Those people will develop a CKD. Most common causes diabetes mellitus. Most common genetic causes autosomal dominant polycystic kidney disease. And most common cause of a death in the CKD patient is atherosclerotic vascular complication. Then management: renal replacement and renal transplant, contraindicated and active sepsis, malignancy, uncontrolled psychosis, active drug dependent, and medical conditions with decrease in the life expectancy, where you may not do the renal transplant. Either a patient is having a malignancy, uncontrolled psychosis, active sepsis, active drug dependence, or maybe the medical condition which can able to decrease the life expectancy. The renal transplant is contraindicated. While RRT, that is your hemodialysis, the RRT patients, you can initiate the dialysis in this patient through the fistula, or maybe through the, like a pigtail catheter, you can initiate the dialysis. But there is a problem. What are the common type of problems you may experience in the post-dialysis patient? Hypotension, muscle cramping, nausea, vomiting, headache, chest pain, and pruritus are the common complications you may experience in the hemodialysis patient. And a severe one, you may experience as a cardiac arrhythmia, sudden cardiac death, disequilibrium syndrome, very, very common. Dialysis disequilibrium syndrome was very, very common. Dialysis reactive hemolysis and air embolism. Air embolism is very, very uncommon, but it is very, very severe. Okay, air embolism is very, very uncommon, but it is very, very severe in terms of your, like severe complication due to your hemodialysis. Okay, these are the common things you may experience in the complication of your hemodialysis paper. Okay, common conditions you may experience in the hemodialysis patient. Then nephrotic syndrome, proteinuria more than 3 plus or 3 to 5 grams per day, proteinuria, hypoalbuminemia, hypergammaglobulinemia, hypercoagulable state due to the loss of your antithrombin 3 and hyperlipidemia, hypercholesterolemia. Hyperlipidemia and hypercholesterolemia will be there. Any patient with a hypoalbuminemia and a hypercoagulable state and the patient is presented with the 3 plus proteinuria, immediately suspected one is your nephrotic syndrome. Nephrotic syndrome is the one you have to suspect people. So here I have marked the highlights of a case, Vinaya. Whatever the clues you may see it in the cases, people. Okay, first one, congenital associated syndrome is your Finnish type, NPHS 1 defect, Finnish type, NPHS 2, familial FSGS, NPHS 3, which is your episola, and apart from the WT1, Wilms tumor, Dennis-Strass syndrome, and LAMB2, which is your Pearson syndrome. Okay, LAMB2, which is your Pearson syndrome. These are the genes associated with the, like as a nephrotic syndrome. Apart from that, here are the clues, type of nephrotic syndrome and what type of clues you may see it in the case vineyard, because nephrotic, nephritic, they always give you as a case. Okay, nephrotic and nephritic, they always give you as a case. So this is a kind of thing, this is a kind of clue, types of nephrotic syndrome and their associated clinical clues you may expect to see it in the exam, people. Very, very important. Okay, I made it very simple for you. This, if you find this word, you can blindly choose. These are the answers. Okay, first one, children, effacement of food process, classical word. When you are looking for the children, effacement of food process, selective proteinuria. Proteinuria of 3 to 5 grams per day. A child with the effacement of food process directly choose minimal change disease, where it may be associated with the Hodgkin's lymphoma and treatment of choice is steroid. Okay, what are the things you may see it for the minimal change disease? Children associated with the Hodgkin lymphoma, effacement of food process, selective proteinuria. 3 plus proteinuria in a child with the effacement of food process. Blindly choose minimal change disease. FSGS, any patient associated with any of these three process, like a HIV, heroin abuse, or sickle cell disease. Along here also you may see the effacement of food process, but there is an increase in the progressing of CRF. You may see it in the FSGS, focal segmental glomerulosclerosis. Effacement of food process associated with the sickle cell disease, heroin abuse, or HIV. Remember, food process effacement in child, minimal change disease. Food process effacement in a HIV, heroin abuse, sickle cell adult, then it is a FSGS, focal segmental glomerulosclerosis. Then the third thing is your membranous nephropathy associated with the Hep B or Hep C, solid tumor as SLE, or maybe due to the drugs, where electron microscope showed a spike and dome appearance. Spike and dome appearance with the Hep B or C or SLE or drugs, membranous nephropathy. Membranous nephropathy. Then MPGN, thick glomerular basement membrane. IF showed a tram track appearance. Tram track appearance with the thick glomerular basement membrane. If you see these two words, membranoproliferative glomerulonephritis is the answer. Apart from the diabetic nephropathy, proteinuria, 3 plus proteinuria or more than 3.5 grams on a day, and proteinuria with the history of type 1 diabetes, and glomerular basement membrane thickening, Kimmel-Stein-Wilson nodule. Very, 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 very classic. So diabetic nephropathy, Kimmel-Stein-Wilson nodule, history of diabetes should be there. Okay, history of diabetes should be there. If not, they won't give you. Okay, renal amyloidosis, there will be a AL and AA type of amyloidosis, Congo red stain and apple green bifringence. Both can able to see that there is a, these two are the classical words for amyloidosis, but there is an increase in the kidney size associated with the AL and AA type. Then you may see it with the renal amyloidosis. Okay, these are the clues of your nephrotic syndrome. So children, effacement of food process. Children, effacement of food process. Minimal change disease. Spike and dome appearance in electron microscope. Spike and dome appearance in electron microscope. That is your membranous nephropathy. And you have a tram track appearance on immunofluorescence. MPGN. Effacement of food processes with the HIV, heroin, or sickle cell disease. FSGS. FSGS. Kimmel-Stein-Wilson nodules. Kimmel-Stein-Wilson nodules. Diabetic nephropathy. Congo red staining and apple green bifringence. Amyloidosis. Congo red staining and apple green bifringence. Amyloidosis. So these are the possible cause, people. These are the possible cause where you have to know. Apart from that, you have a nephritic syndrome, proteinuria, which is less than 3.5 grams per day. Oliguria and RBC cast will be there. So nephritic syndrome, proteinuria less than 3.5, oliguria along with the RBC cast. So immunofluorescent starry sky appearance. Immunofluorescent starry sky appearance. EM subepithelial immune complex deposit. EM subepithelial and immune complex deposit associated with the beta hemolytic strep, then that is a post-streptococcal glomerular nephritis. Okay, starry sky appearance on immunofluorescent associated with the beta hemolytic streptococci, PSGN. Anti-glomerular basement membrane antibody, linear deposits of IgG, and CXR shows pulmonary infiltrate with increase in Delco, good posture. Okay, that is good posture. Then you have a lupus nephritis, immune complex deposition in mesangium and subendothelial and subepithelial spaces where you see the new lupus nephritis. IgA, EM shows a mesangial immune complex deposits, while your immunofluorescence shows IgA-based immune complex deposits in mesangium. Painless recurrent hematuria with the URTI. Painless recurrent hematuria with URTI. Light microscope shows mesangial proliferation. EM shows mesangial IC deposit, which is Ig mediated. And apart from that, you have the recurrent hematuria with upper respiratory tract infection. Increase in Delco, you see it in the good posture syndrome. So starry sky appearance, beta hemolytic streptococci, PSGN. Anti-glomerular basement membrane antibody along with the pulmonary infiltrates with the increase in Delco, good posture. Okay, mesangial deposits, immune complex deposits on mesangium and subendothelial and subepithelial lupus. And IgA, mesangial proliferation and immune complex deposition on mesangium, painless recurrent hematuria with URTI. IgA nephropathy. Okay, IgA nephropathy. With this, we have completed our nephrology, and with this, we have completed our neurology. Two broad systems of your medicine has been completed. Two broad systems of medicine has been completed. Take a 10 minutes of break. Take a 10 minutes of break and come back after 10 minutes so that we can able to proceed with the remaining portion. So today is the medicine, people. So see you all by 4:15. See you all by 4:15 so that we can able to proceed with the upcoming sessions. Okay, we are resuming our section, people. Today we are going to talk about your remaining portion of the medicine. So speaking about the remaining portion of the medicine, where we can, let me open it. So speaking about the remaining portion of the medicine, the next area of interest we are going to see here is your rheumatology, people. So we have talked about the, like in neurology, and we have talked about the nephrology. Next, we are going to talk about the, rheumatology. Speaking about the rheumatology, the clinical features are lupus dermatitis. The first one is your lupus dermatitis. Speaking of a lupus dermatitis, where you see the malar or discoid rash, where you see the malar or discoid type of rash, you may see that classical butterfly type of rash. And apart from that, you may see the severe photosensitivity. You may see the severe photosensitivity, oral ulcer, and arthritis, which is a non-erosive type. And apart from that, several systemic complication, people. Several systemic complications. And speaking about the systemic complications of your lupus nephritis, wire loop lesion is associated with the lupus nephritis. Wire loop lesion is associated with the lupus nephritis. In the brain, it can able to produce a seizure and a psychosis. In blood vessels, TIA, stroke, and myocardial infarction. TIA, stroke, and myocardial infarction. Lungs, interstitial lung disease, diffuse alveolar hemorrhage, ILD and diffuse alveolar hemorrhage, and cardiac pericarditis, myocarditis, and Lippmann-Sachs endocarditis, and GI, increase in ALT and AST. Increase in ALT and AST. Apart from that, antibodies in SLE, we are having a ANA, anti-Smith antibody, anti-phospholipid antibody, anti-double-stranded DNA antibody, and anti-histone antibody. Anti-histone antibody is a very specific one for drug-induced lupus. Drug-induced lupus. And drug-induced lupus, what are the drugs which can able to cause the SLE? There are lot and lot. There are lot and lot. For example, anti-arrhythmic like procainide, disopramide, and propafenone. Anti-hypertensives like hydralazine, ACAs, and beta blockers. Anti-thyroid like propylthiouracil. Antipsychotics like chlorpromazine and lithium. Anticonvulsant, carbamazepine, and phenylate. And antibiotic, INH, minocycline, and nitrofurantoin. Sulfasalazine, hydrochlorothiazide, and lovastatin and simvastatins can able to produce SLE. Lovastatin and simvastatin can able to produce SLE. Treatment, high dose glucocorticoid. Apart from that, mycophenolate mofetil and cyclophosphamide will be there. High dose glucocorticoid along with the mycophenolate mofetil or cyclophosphamide we can able to give. If there is no response, then you can give a monoclonal antibodies like belimumab or rituximab, or maybe the calcineurin inhibitor, you can give for the SLE. So SLE is one of the topic of interest where you may expect at least one question, people. Where you may expect at least one question. Then you have a rheumatoid arthritis. Speaking about the rheumatoid arthritis, female, middle age, morning stiffness and pain is a classical symptoms of rheumatoid arthritis. Female, middle age, morning stiffness and pain. Apart from that, nodular rheumatoid arthritis, splenomegaly, neutropenia, that is Feautres syndrome. Nodular rheumatoid arthritis, splenomegaly, and neutropenia, Feautres syndrome. Rheumatoid factor positive, anti-CCP positive, that is a positive factors for your rheumatoid arthritis. Investigation of choice is MRI. Plain X-ray shows a periarticular osteopenia. Periarticular osteopenia associated with the HLA, DR1, HLA, DRL1, and DMARD of choices, methotrexate. And DMARD of choices, methotrexate. Then you have a systemic sclerosis, multisystemic disorder, like a fibrosis of your skin, blood vessel, and visceral organ. So speaking about the fibrosis of your skin and blood vessel, since it is an unknown cause skin, it can cause a subcutaneous calcinosis, and blood vessels, Raynaud phenomena, lungs, diffuse interstitial fibrosis, atrophy of muscularis, and you may see the kidney renal failure, okay, associated with the systemic sclerosis. Then you have a sarcoidosis, accumulation of T cells and mononuclear phagocytes in various tissues, Pathological findings, sarcoid granuloma and inclusion bodies will be there. What type of inclusion bodies? Shaman bodies, asteroid bodies, residual bodies. Shaman bodies, asteroid bodies, and residual bodies. And the criteria, Scadling criteria, and lambda sign on gallium-67. Scadding criteria and lambda sign on gallium-67 scan. And treatment of choice for positive symptom, prednisolone combined with the steroid sparing agent, cardiac catheter ablation or ICD implantation, neurosurgical management. Neurosurgical management you have to do for the sarcoidosis. So positive symptoms, prednisolone can be treated with the steroid sparing agent. Along with the cardiac catheter ablation or ICD, we can able to place, and neurosurgical management is the one. Asteroid bodies, shaman bodies, and residual bodies are seen in sarcoidosis. Very, 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 very important. Shaman bodies, asteroid bodies, residual bodies, sarcoidosis. Carding criteria and lambda sign, sarcoidosis. Carding criteria and lambda sign, sarcoidosis. Another important MCQ that you have to remember. Another important MCQ that you have to remember in terms of your rheumatology. So rheumatoid arthritis, SLE, rheumatoid arthritis, SLE, and you have the systemic sclerosis and the sarcoidosis are the main one. And apart from that, speaking about the spondyloarthropathies, ankylosing spondylosis, where you see the bamboo spine, dagger sign, access criteria, and HLA-B27 association. So in pathology, we studied about all the HLA association. As I told you, HLA-B27 was very, very important because it contributes for PAIR, I said. Yes or no? PAIR. What is the P stands for? Psoriatic arthritis. A stands for inflammatory bowel disease, ankylosing spondylosis. And 3, I stands for inflammatory bowel disease. And R stands for Reiter syndrome. Or reactive arthritis. Okay, then reactive arthritis, we are having a non-gonococcal urethritis, conjunctivitis, and arthritis, triad of symptoms. Non-gonococcal urethritis, conjunctivitis, and arthritis are the reactive arthritis triad. Drug of choices, high-dose NSAIDs and indomethacin we can able to prescribe. And psoriatic arthritis, symptoms and clinical features are similar to rheumatoid arthritis, where Casper criteria is used. Casper criteria is for psoriatic arthritis. Then vasculitis, we are having a large vessel vasculitis, medium vessel vasculitis, and a small vessel vasculitis. And speaking about the large vessel vasculitis, we are having a granulomatous disease. The first one is your giant cell arthritis. Most common artery involved in the giant cell arthritis is your temporal artery. Okay, this is a temporal artery arthritis or giant cell arthritis. Apart from that, you may have the Takayasu arthritis, where you see the pulseless arthritis associated with the aortic arch. That's why it is also known as aortic arch syndrome, and the pulseless arthritis. So that is your Takayasu arthritis. While medium vessel ones, speaking about the medium vessel one, the important one is your polyarthritis nodosa, which is an immune complex mediated. Immune complex mediated is PAN, polyarthritis nodosa, which is associated with the hepatitis B and C, and treatment of choices cyclophosphamide and steroid. Apart from that, anti-endothelial cell antibodies, which is associated with the Kawasaki, where you may see the mucocutaneous lymph node syndrome, and you may also see the strawberry tongue, mucocutaneous lymph node syndrome is associated with the Kawasaki disease. Which is an anti-endothelial cell antibodies are there. And vasculitis without, like a small vessel vasculitis. Speaking about the small vessel vasculitis, we are having a SLE, and we are having a HSP, and we are having a cryoglobulin vasculitis, and good pasture disease. And SLE vasculitis, cryoglobulin vasculitis, we have already discussed. So only one thing we are going to talk about is Keynote stone line purpura. This is a HSP image-based question, people. And this is a HSP image-based question. And apart from that PAN, you may see the saddle nose deformity and granulomatosis with the polyangiitis. This is the image-based question that may ask you. Okay, so far. Apart from that, this ANCA positive, C ANCA positive, vaginous granulomatosis, P ANCA positive, that is your microscopic polyangiitis or Church-Strauss syndrome. Microscopic polyangiitis are Church-Strauss syndrome. You may see the P ANCA, while vaginous granulomatosis, you may see the C ANCA positive. You may see the C ANCA positive. So this is all about your rheumatology and vasculitis, people. Then endocrinology, diabetes mellitus. Diabetes day is November 4th. Symptoms, as you know, polyuria, polydipsia, polyphagia, tiredness, weight loss, and RBG, random blood glucose of more than 200. You already knew that. Yes or no? So now speaking about the type 1 diabetes, which is a beta cell destruction, type 2 insulin secretory defect, gestational, which is occurring in pregnancy, like maturity onset diabetes mellitus in a young patient, which is due to the inheritance defect, and 1.5 type diabetes mellitus is ketone prone, and LADA, which is a latent autoimmune diabetes mellitus in adults. So 1.5, 1.5 is two types, KPD and LADA. One is due to the insulin deficiency due to beta cell destruction, and 1.5 is due to either a ketone prone diabetes or it may be a latent autoimmune diabetes in adults. T2, progressive insulin secretory defect. T3, double diabetes or Alzheimer's dementia diabetes mellitus. Diabetes associated with Alzheimer's dementia, which is type 3. Type 3C associated with the pancreatic disease, and type 4 is autoimmune. Okay, type 4 is autoimmune condition. So type 1 to 4 and GDM and MODY was there as per the types of diabetes mellitus. Okay, then diabetic ketoacidosis. What is a diabetic ketoacidosis? Blood glucose level of more than 250 mg per deciliter is diabetic ketoacidosis, which is ketones positive, and serum bicarb is less than 15. Serum bicarb is less than 15, and anion gap should be more than 10. Anion gap should be more than 10 for a diabetic ketoacidosis. Increased anion gap metabolic acidosis we have studied in the acid-base disorder, which is the cause of the increased anion metabolic acidosis is mud piles. Yes or no? Methanol, uremia, diabetic ketoacidosis. Yes or no? On the D, diabetic ketoacidosis, where you may see the increased anion gap metabolic acidosis. Symptoms of DKA: tachycardia, Kussmaul's respiration, severe hypothermia, altered sensorium and shock. Altered sensorium and shock. So fruity odor in the fruity smell. Patient is smelling fruity, and the patient is having a chill body with the altered sensorium and Kussmaul breathing. DKA will be suspected. Urine ketone bodies will be positive. Blood glucose will be more than 250. Bicarbonate is less than 15, where the anion gap is more than 10. So increased anion gap metabolic acidosis pattern will be seen. Then triple H, hyperosmolar hyperglycemic state, HHS, where you see the severe dehydration, blood glucose of more than 600 and bicarbonate of more than 15, you may see. Management: HbA1c less than 9, monotherapy. HbA1c 9 to 10, dual therapy. A1c more than 10, where you see the combination with the injection therapy. Combination with the injection therapy. So OHS we have done after 3 months, and look for it. If it is a monotherapy, then switch it to the dual therapy. If it is dual therapy, then switch it to the triple therapy. If the patient is on the triple therapy already, then you have to switch it to combination injection therapy. You have to switch it to combination injection therapy. So apart from the drugs and all, we have already studied about the drugs and their contraindications back in the pharmacology itself. So I don't want to do the drugs part here. So next is a pulmonology. Speaking about the pulmonology, which is a type 1 respiratory failure, defect in the alveolar filling. Okay, type 1 is due to defect in alveolar filling, where you see the normal ventilation, abnormal diffusion. Normal ventilation, abnormal diffusion. The causes could be ARDS and bacterial infection, shunt, emphysema or embolism, interstitial lung disease. Shunt, emphysema or embolism, interstitial lung disease will be there. Apart from that, lateral PaO2 will decrease, PaCO2 will be normal, alveolar arterial gradient partial pressure will increase, and treatment is mechanical ventilation with decreased tidal volume. Type 1 respiratory failure is normal ventilation, abnormal diffusion. It's just seen in ARDS, bacterial infection, shunt, emphysema, and interstitial lung disease, where you may see the arterial PaO2 decrease, PaCO2 normal, PaO2, alveolar arterial gradient will rise, and mechanical ventilation with decrease in tidal volume. And then type 2 respiratory failure, where you see the normal diffusion but abnormal ventilation, mostly associated with, like Guillain-Barré and MNDs, kyphoscoliosis, myasthenia gravis, any muscular disorder which can able to cross the improper ventilation, any muscular disorder or any obstruction that can able to cause an improper ventilation could result in type 2 failure, people. Okay, any infection or shock or emphysema or distress or any interstitial lung disease that can associated with the impairment in diffusion, that is type 1. Impairment in ventilation, that is type 2. You have to know that. And what will be the features? PaO2 will decrease. PaO2 will decrease. PaCO2 will increase, and alveolar arterial gradient will be normal. Alveolar arterial gradient will be normal in the type 1 and type 2, type 2 respiratory failure. Type 2 respiratory failure. So type 1 respiratory failure, diffusion defect. Type 2 respiratory failure, ventilation defect. Okay. So anything that can obstruct can produce as a ventilation defect, which is a type 2 respiratory failure. Okay. Asthma, airway obstruction, which is totally reversible. Acute airway obstruction. I rather want to use the word acute airway obstruction, which is totally reversible, starting from 3 years of age, where you see 3 C's: Crayola bodies, Crashman spirals, and Crayola bodies, Crashman spirals, and what are the 3 C's of asthma we studied in the pathology, people? Faster. What are the 3 C's of asthma we studied in the pathology? Crayola bodies, Crashman spirals, and charcoal-laden crystals. We studied here. Yes or no? Anyway, fine. Intrinsic asthma, which is generally predisposed, genetically predisposed individual. And what type of triad you may see? Samton's triad. Okay, Samton's triad you may see, where it is associated with the aspirin abuse, nasal polyps, and bronchial asthma. Aspirin, nasal polyps, and bronchial asthma are the Samton triad associated with the asthma. And what type of symptoms? Paroxysmal cough, dyspnea, and wheezing. Okay, infection, RSV, mycoplasma, chlamydia is associated with the asthma, and environmental stimulus could be there. Anything that can able to trigger asthma, which is a severe bronchoconstriction, which is totally reversible. Drug investigation of choices, spirometry, and methacholine challenge test we can able to give. We studied that in the pharmacology section also. Methacholine challenge test, carbachol, bethanacol, methacholine. Apart from that, you may have a RAST, pinprick test, and you may also have a fraction of exhaled nitric oxide. Fraction of exhaled nitric oxide. And treatment of choice, you already know, SABAs and LABAs. SABAs and LABAs. Apart from that, you may see the corticosteroids. Apart from that, you may see the bronchodilators, which are cholinergic antagonists. Yes or no? So SABAs, salbutamol, albuterol are the SABAs. Salmeterol, formoterol are the LABAs. Okay, longest acting one. First, you try the initiation of your SABAs and LABAs and corticosteroids, and then finally you can try the bronchodilators. That's the stages of your asthmatic treatment, people. Those are the stages of your asthmatic treatment. Then COPD, associated with the smoking and associated with the history of smoking or smoking, and alpha-1 antitrypsin, previous history of TB, GERD, and low socioeconomic status. Okay, low socioeconomic status will be there. COPD, types of COPD. First one is your chronic bronchitis and emphysema. So emphysema, speaking about the emphysema, pink puffer, as I said, 3 types: centriacinar, panacinar, and paraseptal. Centriacinar is associated with the smoking. Panacinar is associated with the alpha-1 antitrypsin, and paraseptal is associated with the pneumothorax. Okay, centriacinar, panacinar, paraseptal. Centriazinar is smoking. Panazinar is alpha-1 antitrypsin, while paraseptal is pneumothorax, associated with the pneumothorax. So what is the emphysema? Dilation of your distal alveoli and terminal bronchiole, which can able to prevent the gas exchange, is so-called as emphysema, which is of three types: centriazinar, panazinar, and paraseptal. Centriazinar is associated with the smoking, while panazinar is associated with alpha-1 antitrypsin, while paraseptal is associated with the pneumothorax. Investigation of choices is spirometry, and we can able to classify them with the mild, moderate, severe, and very severe. And speaking about the mild, moderate, and very severe, mild one, FEV1 ratio will be, FEV1 percentage will be more than 80, moderate 50 to 80, severe 30 to 50, and very severe less than 30. X-ray shows pulmonary vascular markings, and CT chest shows a bulla. Apart from that, chronic bronchitis, cough of more than 3 months in 2 consecutive years, and you have this, acron limitation, which goes for the tripod position. One of the classical thing we associated with the chronic bronchitis, which is your tripod position, which is so called as acro limitation. Apart from that, patient may do the pursed lip breathing, and barrel shaped chest will be there. Pursed lip breathing and barrel shaped chest will be there, and you may see the secondary polycythemia. So treatment of choice: counsel the patient to quit smoking first, and drugs to stop smoking you can initiate. So first, quitting of smoking, pulmonary rehabilitation, O2 therapy, and O2 therapy. Supportive drugs, we can able to give a bronchodilators and corticosteroids, and if not, phosphodiesterase 4 inhibitor. Okay, if not, phosphodiesterase 4 inhibitor. On a severe cases, we can do the lung transplantation, and on a severe cases, we can do the lung transplantation. Then you have a bronchiectasis, abnormal permanent dilation. Abnormal permanent dilatation is bronchiectasis, where the types are tubular, varicose, and cystic one. Most common location is left to lower lobe. Now the syndromes associated with the primary bronchiectasis are important, people. Syndromes associated with the primary bronchiectasis are important, which is a Monier-Quinn syndrome, where you see the tracheobronchiomegaly, William Campbell syndrome, where you see the congenital absence of cartilage, yellow nail syndrome, where you see the pleural effusion, yellow nail bronchiectasis, and cartilaginous syndrome, ciliary dyskinesia, you may see, that is a situs inversus, and bronchioectasis and infertility. Okay, situs inversus, bronchioectasis, and infertility are the features of your cartilaginous syndrome, where you see the mucociliary dyskinesia. Apart from that, Young syndrome, same features, especially azoospermia will be there. So what are the syndromes associated with the primary bronchiectasis? Monier-Quinn syndrome, where you see the tracheobronchiomegaly, William Campbell syndrome, where you see the congenital absence of cartilage, yellow nail syndrome, where you see the pleural effusion, yellow nail along with the bronchiectasis, and then you have a cartilaginous syndrome, where you may see situs inversus, bronchiectasis, and infertility. Young is also associated with them, except Young shows azoospermia. Okay, then you have a secondary bronchiectasis, which is associated with the infection. Upper part is associated with the cystic fibrosis and post-radiation, while middle part, MAC infection. Lower part, either it is due to the aspiration, or it is due to the hypergammaglobulinemia. Treatment of choices: maintenance of airway and aerosolized DNA mucolytics. Apart from that, inhaled corticosteroid. So steroids is a choice for the lungs. But steroid, as I say, steroid is also a double-edged sword. You have to be very, 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 very careful. Apart from that, in the bronchiectasis, you may see the signet ring appearance, tram track appearance, honeycomb appearance, and tree in bud appearance. So what are the named appearance? You may see it in the bronchiectasis: signet ring appearance, tram track appearance, honeycomb appearance, and tree in bud appearance are the appearances you may expect to see in the bronchiectasis. Then you have a cystic fibrosis, CFTR gene mutation. CFTR gene mutation. Most common mutation is associated with the lumacaftor 1. And apart from that, most common cause is your exocrine pancreatic insufficiency and chronic lung disease in children. And most common lobe affected in cystic fibrosis is upper left lobe. Upper left lobe. Treatment is antibiotic, lung transplant, and recombinant DNA is, and ivacaftor is the drug we can able to give. And diagnosis, screening test, sweat chloride test. Very, very important MCQ. Sweat chloride test is used in cystic fibrosis. Okay, so sweat chloride test is used in cystic fibrosis. Diagnosis is nasal transmembrane potential difference you can able to see. And apart from that, these are the important things you have to know about the cystic fibrosis. Autosomal recessive, CFTR gene mutation, where most common causes exocrine pancreatic deficiency and chronic lung disease in children. Most common lobe affected is left lobe. Treatment of choices antibiotic, lung transplant, recombinant DNAs, and ivacaftor. Apart from that, screening test is your sweat chloride test. Sweat chloride test. Then you have a ARDS, which is a shock lung, where you may see the hypoxemia, acute respiratory distress plus diffuse pulmonary infiltration. Hypoxemia, acute respiratory distress plus diffuse pulmonary infiltration are the three things you may see it in the ARDS people. So criteria, acute onset, as we said, ratio of PaO FY2 will be there, and diffuse lung pulmonary features in the X-ray you may see. And apart from that, diffuse pulmonary edema features in the X-ray you may see. Apart from that, you may see the Schwann-Scans catheter. Okay, you may see the Schwann-Scans catheter. On the Schwann-Scans catheter, the PCWP, pulmonary capillary wedge pressure, should be less than 18. PCWB should be less than 18. X-ray shows bat wing appearance. One of the classical MCQ people. X-ray shows bat wing appearance, and treatment, treat the underlying cause first. Treatment is treat the underlying cause first. Okay. Then you have this, this acquired lung diseases, silicosis. You may see the silicosis, acute silicosis. You may see the miliary pattern. Chronic silicosis, you may see the opacification and axial calcification. And apart from that, you may see most commonly involved lobe in the silicosis is upper lobe. Only 4 words, people. Okay. One is a miliary pattern is seen in acute silicosis. Opacification and axial calcification is seen in chronic, while most commonly involved is upper lobe. Asbestosis, like there are 3 types, white, brown, and blue. Among that, white is a chrysolite and blue is a crocodolite. Okay, chrysolite and crocodolite. Chrysolite is the most common form, while crocodolite is the most dangerous form. Chrysolite is the most common form, while the crocodolite is the most dangerous form. Apart from the clinical features, pleural effusion, pleural plaques will be there. Pleural effusion, pleural flakes will be there. Apart from that, it may progress into malignant mesothelioma, and X-ray shows holy leaf pattern. Okay, X-ray shows holy leaf pattern. Bronchoalveolar lavage shows 2 important things: sheikh kebab bodies and ferruginous bodies. Very, 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 very important. Sheikh kebab bodies and ferruginous bodies are seen in asbestosis. Bat wing appearance is seen in. Bat wing appearance is seen in. Bat wing appearance is seen in ARDS. And apart from that, shaman bodies, asteroid bodies are seen in. Shaman bodies and asteroid bodies are seen in. Faster, faster, people. Shaman bodies and asteroid bodies are seen in. Type faster, type faster. Shaman bodies and asteroid bodies are seen in. Shaman bodies and asteroid bodies are seen in. Sarcoidosis, you forgot that. Sarcoidosis, people. Shaman bodies, asteroid bodies are seen in sarcoidosis. You should know that. You should know that shaman bodies and asteroid bodies are seen in sarcoidosis. Okay. Apart from that, now speaking about that important stuffs, speaking about the important things. So speaking of the next area of interest, speaking about the next area of interest, people, we are having this. We are having this hepatology. So hepatitis we have already seen. That's why I'm not doing the hepatitis here. So hepatitis we have already seen. So that's why I'm not seeing here. But there are situations and markers in hepatitis are pretty important. Situation and markers in hepatitis are pretty important. Infection plus symptoms, where the marker is HBsAg will be more. Acute hepatitis B, HBsAg and anti-HBc IgM will be there. Window period, anti-HBc IgM will be there. Recovery period, anti-HBs, anti-HBc IgM will be there. And window period, anti-HBs, anti-HBc IgM will be there. Remote recovery, anti-HBs, anti-HBc IgG will be there. Chronic hepatitis, anti-HBc IgG and HBsAg will be there. And post-vaccination, you may see anti-HBs antigen. And post-vaccination, you may see anti-HBs antigen. Chronic hepatitis, anti-HBc IgG and HBsAg, while remote recovery, anti-HBs, anti-HBc IgG. And apart from that recovery period, anti-HBs, anti-HBc IgM. Window period, anti-HBc IgM. Acute hepatitis B, HBsAg, anti-HBc IgM. Infection, HBsAg and HBeAg. HBsAg and HBeAg are the things you may see it in the infection. So these are the possible scenarios and possible situations where you may see. Okay, 1 second. How about now? Can you able to see the screen properly? If you could able to see the screen properly and hear my voice, type yes on the chat box. If you could able to hear my voice and see the screen properly, type yes on the chat box. Type yes on the chat box. If you could able to hear my voice and see the screen properly, type yes on the chat box. Okay, now speaking about the autoimmune hepatitis, people. Speaking of autoimmune hepatitis, we are having a type 1, type 2, type 3. Type 1 is associated with the anti-actin. Type 2 is anti-LKM. Type 3 is anti-soluble liver antigen 1. Okay, all of the autoimmune hepatitis, you give a corticosteroid, and for drug-induced, alpha-methyl dopa and isoniazid. Alpha-methyl dopa and isoniazid. Then you have a chronic histological activity index will be there. And apart from that, Metavir score will be used for the chronic hepatitis. And the treatment of choices, interferon alpha, tenofovir, lamivudine, and entecavir. Okay, tenofovir, lamivudine, and entecavir. Okay, apart from that, liver cirrhosis, which is the end-stage liver disease, where you see the normal hepatic parenchymal disruption along with the fibrosis, and portal hypertension is one of the causes. And apart from that, there will be a decrease in detoxification in the liver cirrhosis. Whenever there is a decrease in detoxification, there will be an altered mental status, asterexis, coma, gynecomastia, spiroangiomata, and jaundice. And due to the lack of protein synthesis, you may see the albuminemia and coagulopathy in the liver cirrhotic patient. So end-stage liver disease and normal hepatic parenchymal disruption will be there. Pulmonary hypertension will be there. Decrease in detoxification could produce a jaundice, and decrease in protein synthesis could produce hypoalbuminemia and coagulopathy. Then you have Wilson disease, accumulation of copper, ATP7B gene defect. Very classical one. ATP7B gene defect. Treatment is D-penicillamine, rhodamine stain, or arsenine stain. KF rings will be there. KF rings, rhodamine stain or arsine stain, ATP7B gene defect, D penicillamine defect, and apart from D penicillamine is a drug of choice. And apart from that, you may see the sunflower cataract. You may see the sunflower cataract. Next is a primary sclerosing cholangitis, where you see the periductal fibrosis with the onion skin appearance. Contract imaging shows a bearded appearance. Bearded appearance is seen in primary sclerosing cholangitis. Bearded appearance is seen in primary sclerosing cholangitis. Then you have a cardiology, people. Speaking about the cardiology, CAD is the first one. So CAD, 70% occlusion can able to produce a chest pain. Okay. So if you are looking after the CAD, it could be a stable angina or unstable angina, or maybe the myocardial infarction. Speaking of a myocardial infarction, there will be a rise or fall on the marker. What type of marker you may see in the myocardial infarction? Remember with the mnemonic of my time call. Okay, my time call. M for myoglobin, T for troponin, C for CKMB, A for AST, and L for LDH. And L for LDH. And ECG, hyperacute tall T wave will be there. Hyperacute tall T wave will be there. Apart from that, ST elevation will be there, T wave inversion, or pathological Q waves. If you see 4 of these things, you can suspect a MI. And echo shows akinesia or hypokinesia along with the regurgitation. Now, speaking about it, people, MI. MI is another important thing you are going to see here, people. So what are the things you may see it in the MI? A patient comes with the angina mostly. Patient comes with the angina mostly. Patient is coming to you with the chest pain to the ED. What you are trying to do? You are trying to do the ECG first. You are trying to do the ECG first, and ECG shows there is a ST elevation in the leads, and there is also a hyperacute tall T wave, and the T wave inversion is also there, or maybe pathological Q wave is also there. With the AECG, you have concluded that the patient is having a MI. That the patient is having a MI. Immediately, you are initiating the loading dose, where you are giving a aspirin 75 mg 4 tablet and clopidogrel 300 mg for 300 mg tablet, or if not 300 mg, 150 mg of 2 tablets, or 75 mg of 4 tablets. Aspirin 300 mg and clopidogrel 300 mg you are giving, and you are initiating the loading dose, and then you are sending it to the referral center. While the referral center person is doing an echo, echo will have this following words: hyperkinetic or akinetic regional wall motion anomaly, RWMA positive, RWMA positive with a hyperkinetic or akinetic left ventricular wall or left atrial wall or right ventricular wall or right atrial wall. Any of the wall will be which is abnormal, which will be visible in that echo. Okay, either maybe a long axis view or short axis view, or like 4-chamber view. All this view has been taken and that found that there is a regional hypokinesia that confirms the MI. So you initiate him on O2 supplement, nitrates, aspirin, clopidogrel, and morphine, and you have to initiate him on any painkillers also. So anti-anginal, dual antiplatelets, along with that O2 supplement, and you are giving him a morphine or maybe painkiller. Okay, then you are having that suspicion is there. Then you are doing a marker. Marker was also positive. Troponin I was positive. Troponin I was positive. Then it is a NSTEMI. Okay, if you can't able to find a ECG findings and you do the troponin I was positive, then it is suspected to be the NSTEMI. While if the ECG changes has been shown, then it is a STEMI. Okay, so fine. If both are negative and ECG is not showing anything, then it is an unstable angina, people. Then it is a unstable angina. So speaking about the angina, we are having a 3 types of angina: chronic stable one, chronic unstable one, and then you have a Prinzmetal angina. You have a Prinzmetal angina. Okay, chronic stable angina, pain increases by exacerbation or pain decreases by the rest. Okay, pain increases when you are working, decreases by rest, and pain lasts for 5 minutes. ECG shows normal. When you do the TMT, TMT will become positive. Okay, TMT will become positive. And when you stop, whenever ST depression is more than 0.1 mm, or a systolic BP falls more than 10 mm of Hg, or patient may develop a ventricular tachycardia, then you may think about the chronic stable angina. You immediately stop it with the TMT positive. Then chronic unstable, which is a crescendo pain, where pain increases by the exercise, and when you are trying to relax, the pain will not decrease. Previously, for the stable angina, whenever the pain increases by the exercise, when you are relaxing, then the pain will vanish for 5 minutes. For an unstable patient, the pain will not vanish. It will last for more than 20 minutes, and treatment is to reduce the pain. ECG showed no changes. Troponin was negative. Cardiac marker was normal. All the cardiac markers normal. ECG shows nothing, and the pain is there. Then immediately our management is mostly pain management. And for Prince metal angina, which is due to the transient vasospasm, treatment of choice is calcium channel blocker. So you find that the patient came to you with the chest pain. You did the markers and ECG. Markers and ECG were negative. That is a unstable angina, where your primary goal is to be the pain management. If it is a stable angina, or if it is a stable angina, that won't come to the emergency department. Okay, unstable angina, patient came with the emergency department, you reduce the pain. And you sent for the troponin or the cardiac markers and ECG. ECG was negative, but cardiac marker troponin was positive. Then it is a NSTEMI. If ECG shows any changes, then it is a STEMI. Okay. Then vessel occlusion, you have to do echo. You are doing echo showed a regional wall motion abnormalities such as hypokinesia or akinesia was there. That confirms the recent MI. Then immediately you have to do the angiography to rule out the vessel occlusion. Once you do the angiography, then you can able to proceed accordingly to the treatment of option. Either you can do the PTCA or you can do the CABG depending upon the patient option and depending upon the vessel occlusion location. Okay, or thrombus location. Okay, so these are the thing we are doing. And apart from that, heart sounds and murmurs, area of auscultation is very, very important. Pulmonic, second ICS, aortic, second right costal cartilage, mitral, fifth ICS crossing a mid-clavicular line, tricuspid, lower part of sternum towards the right side, lower part of sternum towards the right side. While the normal heart sound, S1 is seen in isovolumetric contraction, S2 is protodiastole, S3 is rapid filling, S4 is atrial contraction. We already studied. Fixed splitting is seen in ASD, wide splitting is seen in RBB and MR and VSD, and paradoxical splitting of S2 is seen in left bundle branch, AS, systemic hypertension, WPW syndrome, and left heart failure. Apart from the systolic murmur, ASRPS, MRRTR, and VSD, while diastolic murmur, ARRPR, MSR, TS, you may see. Continuous murmur is seen in PDA and VSD. Okay, how do you remember the systolic and diastolic murmur, people? How do you remember the systolic and diastolic murmur? Now we are moving on to the cardiac cycle. Cardiac cycle. Consider this is your mitral valve at like AV valve. Consider this is a AV valve, and this is your semilunar valve. This is your semilunar valve. Okay, fine. Now, whenever there is a systolic defect during the systole, which indicates the ventricular systole, during the ventricular systole, which valve will open and which valve will close? Which valve will open and which valve will close? During the systole, your semilunar will open. Semilunar will open and your AV valve will close, right? AV valve is closed. Yes or no? Am I right or wrong? So we are having a two condition, people. One is your stenosis, which is an improper opening. Improper opening. Another one is your regurgitation, which is an improper closing. Regurgitation, which is an improper closing. Improper closing. Okay. So we know whenever the systole is happening, the blood will be flushed out of in two directions. Yes or no? Blood can be flushed out of in two directions. If this valve is not closed properly, or if this valve is not opened properly, then the blood will be you having a strain in pushing it when the ventricle will be having a strain and pushing it right, yes or no, then you may produce a systolic murmur, yes or no, systolic murmur. So improper closure means what? Regurgitation. So AV valve regurgitation and semilunar valve stenosis could result in systolic murmur. So systolic murmur, semilunar valves are your aortic and pulmonary valve, aortic and pulmonary, while your AV valve are bicuspid and tricuspid. Yes or no? Bicuspid and tricuspid. Bicuspid and tricuspid valve. Tricuspid and bicuspid valve. So speaking about that, what type of systolic murmur could be resulting in? Semilunar stenosis and AV regurgitation. So what stenosis will be there in systolic murmur? Aortic stenosis or pulmonic stenosis followed by mitral or tricuspid regurgitation. Aortic or pulmonary stenosis are followed by mitral or tricuspid regurgitation. You see the systolic murmur. While diastole, it exactly opposite. Aortic regurgitation or pulmonary regurgitation and mitral stenosis or tricuspid stenosis, you may see the diastolic murmur. While the continuous machinery murmur is seen in VSD and PDA, patent ductus arteriosus. Okay, this is all about the heart murmur, people. This is all about the heart murmur. Then you are talking about the like infective endocarditis. Speaking about the infective endocarditis, where the colonization of your bacteria on your walls, the most common ones are your mitral walls over the aortic wall, and vegetation could be single or multiple or even with more walls. And a clinical feature: fever, fatigue, weight loss, cardiac murmurs, splenomegaly, petechiae, and you may see there is a oscillar node, roth spot, and you may also see that there is a, on the finger, you may see splinter hemorrhage, roth spots, splinter hemorrhage, roth spot, and oscillar nodes are the three things. Roth spots and oscillar nodes are the three things you have to remember in terms of your infective endocarditis, people. In terms of your infective endocarditis, you have to remember these things. Apart from that, culture should be positive. Culture should be positive. And what type of complication you may see? Infection is there, so septicemia will be the complication. Pulmonary emboli will be the complication because vegetations are happening, blood will be stasis, thrombus or embolus formation will be commonly there. Apart from that, arrhythmias and heart failure will be there because of a destruction of the wall. And apart from that, you may see rupture of chorda tendineae and renal failure and aneurysm. Okay, vessel aneurysm, renal failure, rupture of chorda tendineae, arrhythmias, congestive heart failure, and pulmonary emboli, septicemia are the complications of your infective endocarditis. So what are the types? Libman-Sachs endocarditis, carcinoid syndrome association, and marantic endocarditis. So Libman-Sachs, less common and associated with the SLE. SLE is associated with Libman-Sachs endocarditis. Okay. And apart from that, carcinoid syndrome, 5-hydroxytryptamine levels will be elevated, which can able to cause the endocarditis. Then sterile vegetations is associated with marantic endocarditis. Okay, sterile vegetation is associated with marantic endocarditis. So then we are going to talk about the antibodies, people. Speaking about the antibody, this table is 7-star rated topic, people. This table is a 7-star rated table. You should not miss. Each and everything is important, people. Anti-acetylcholine esterase antibody is seen in myasthenia gravis. Myasthenia gravis. Beta-2 glycoprotein, APLA. Antiphospholipid antibody syndrome. Okay, antiphospholipid syndrome. You may see the anti-beta-2 glycoprotein. ABG, we used to see like ABGPCR, anti-beta-2 glycoprotein couple receptor, we used to say. Okay, ANA, SLE, cardiolipin, SLE, and antiphospholipid, double-stranded DNA and Smith, SLE, histone, drug-induced SLE, UNRP, mixed connective tissue, rheumatoid factor, rheumatoid arthritis, and anti-CCP, rheumatoid arthritis, SSA, SSP, Sjogren's syndrome, SCL70, scleroderma, centromere crust syndrome, antisynthetase, polymyositis or dermatomyositis, and primary biliary cirrhosis, mitochondrial antibody, primary biliary cholangitis, anti-smooth muscle, hepatitis type 1, PANCA, microscopic polyangiitis, Church-Strauss syndrome, and ulcerative colitis, while CANCA, granulomatosis with the polyangiitis, that is your vaginous granulomatosis, APLA2, primary membranous nephropathy, hemidesmosome, bullous pemphigoid, desmoglein pemphigus vulgaris, microsomal Hashimoto thyroiditis, that is anti-TPO, that is Hashimoto thyroiditis, TSH, Graves' disease, and anti-endomysial or transglutaminase, celiac disease, glutamic acid decarboxylase or islet cell cytoplasmic antibodies, type 1, anti-parietal cell, pernicious anemia, anti-GBM, good posture. Among that, what are the things which is important? I'm going to mark it in the red. You should not, even if you can't able to remember the whole table, you can remember at least this. Glomerular basement membrane, parietal cell, TSH, anti-TPO, desmoglein, hemidesmosome, and APLA2, anti-phospholipase A2, and apart from that, PANCA, CANCA, and apart from that, SCL70 and centromere, and apart from that, SSA, SSB, anti-CCP, anti-histone, and double-stranded DNA, and anti-cardiolipin ANA. All three anti-ACH. At least remember these things so that you can able to answer most of the question. Anti-TPO, Hashimoto thyroiditis, TSH, Graves' disease, parietal cell, pernicious anemia, glomerular basement membrane, good posture syndrome, PANCA, microscopic polyangiitis, Church-Strauss syndrome, ulcerative colitis, while CANCA, vaginous granulomatosis, anti-centromere crust syndrome, SCL70, scleroderma, SSA, SSB, Sjogren's syndrome, CCP, rheumatoid arthritis, histone body, drug-induced lupus, double-stranded DNA and anti-Smith, SLE, anti-cardiolipin and lupus, SLE, ANA, SLE, anti-ACH, myasthenia gravis. Myasthenia gravis. Apart from that, this is used to check the fluid thrull, test for, ascites, and a ptosis for the myasthenia gravis image, and peritibial myxedema, which is associated with the Graves' disease, and Tressau-sign, hypocalcemia, Chausteckstein, hypocalcemia, and shifting dullness, you may see it for the ascites, and auscultation points we have done. Already auscultation points we have done. So these are the image-based question, people. With this, we have completed cardiology, rheumatology, endocrinology, hepatology, and you have this, endocrinology, hepatology, rheumatology, cardiology, nephrology, neurology. Everything has been covered in the medicine. The important features you need to know has been covered up over here. So high yield area, people. Remember the neurology, and remember the cardiology, and remember the nephrology, and remember the rheumatology. These four are the high yield areas in the medicine. While rest are all, at least you have studied somewhere in some subject, you can able to answer. But these questions are typically mostly comes here in the medicine itself. There is a hematology, we covered that in the pathology itself. That's why I didn't do that. Okay. So there is a hematology and there is a rheumatology, endocrine, and these things are the important things. Speaking about the critical care medicine, which you have additionally studies in the medicine, where we had covered mostly important critical care diseases in their respective system itself. For example, heart disease, myocardial infarction we have covered, stable angina, unstable angina we have covered, and we have covered the stroke management, we have covered the epilepsy management, we have covered the hepatitis and the microbiology, and also in PSM. So we have covered most of the things in the case of our AKI, associated sepsis, and diabetic nephropathy, dialysis indications. We have covered that in the nephrology section itself. So critical care medicine we split up and we covered in each system additionally. Okay, so there is additional things. Medicine is very, very rare subject. You could get a good scores very, very rarely unless your basics are very good. Okay, so I suggest you to go through this and read this system perfectly so that at least you can able to score 50 to 55% of the question if you cover these systems. Okay, clear about that? So tomorrow we will see you with another subject. Maybe tomorrow will be the holiday, I guess. I need to speak because it's been almost like 7 days, I guess, since I given you a break. So we need to speak. If there is no break, then we can proceed with tomorrow. I'll speak with them. How about you? You want a break? If you want a break for tomorrow, kindly let me know. And then I will speak with them regarding that. And see you all tomorrow with the new subject. And have a nice day, people. Okay, we have covered the medicine. We have covered the medicine.